urologist, and he's going to look at the issue of lower urinary tract symptoms in men and women. Dominic currently works at St George Hospital as a VMO, and also privately at St George Private and Hurstville and the Mater Hospital. Dominic graduated in Melbourne from the University of Melbourne with honours, and then did his urology training in Australia. He subsequently has completed multiple fellowships overseas, including uro-oncology in Cambridge, some pelvic floor and urinary tract reconstruction in Texas. Also in Texas, female pelvic medicine reconstruction, and also minimally invasive surgery with robotics and laparoscopy. So all those areas, did fellowships over in the States. Of course, he's a member of the College of Surgeons and is Australia board certified in urology and holds a full medical license in Texas, USA. But Dominic's main interest areas are female urology, incontinence, pelvic organ prolapse, male incontinence, voiding dysfunction and urethroplasty, neurourology, sexual dysfunction, pelvic floor and urinary tract reconstruction, and minimally invasive surgery for uro-oncology. So covers a broad range of urology aspects, and we're very pleased to have him tonight present to us. So I'll hand over to Dominic, and please, as you think of questions, send them through and I'll have a look at those, and at the right times we'll try and ask those of Dominic and get some answers. So thanks for joining us, and I'll pass over to Dominic. Thanks.
Thank you, Matt. Welcome everyone for this, and thank you for this opportunity to actually present my talk to you all. As Matt was alluding to, we're going to be presenting on lower urinary tract symptoms in men and women, which is a very, very broad topic. However, we'll get through them pretty quickly and have plenty of time for you to ask questions. Without further ado, I'll just start the presentation. So basically, the outline of the talk will be just defining LUTS and also looking at the classification, looking also at the etiology between men and women, what the prevalence is of this particular urinary symptoms, and then how we assess and treat respectively, and who and when to refer in terms of the work that we see from you all, which is very important. So urinary tract symptoms is actually a term that was coined back in the 1990s, and it just describes an array of symptoms affecting control and quality of urination within the urinary tract. So more often than not, 50% of the time it resolves on its own, and also the underlying cause is not apparent when you assess these patients. So it can be quite frustrating, but it is a common presentation to your practice. And it's actually divided into 3 types according to the ICS classifications. So when we talk about LUTS, we talk about storage symptoms, which is daytime frequency, urgency, nocturia, with or without incontinence. And then in terms of the voiding symptoms, these are the ones that you normally encounter in elderly men who have a slow stream, for example, or that they have hesitancy, or they actually dribble at the end. But that itself has actually been coined into another subcategory called post-micturition, in which post-micturition dribble and the feeling of incomplete emptying, it's sort of in its own, but is often associated with obstructive or voiding symptoms. So I think if you actually break down how you actually elicit clinical features with your patients, you can actually break them down like that, which is a lot simpler. So as I said before, there are many, many causes of lower urinary tract symptoms because the bladder only responds in certain ways. Either it keeps urine or it wants to expel urine. So for all intents and purposes, for men, the most common cause that we see is benign prostatic enlargement. And in women, it is actually lower urinary tract infection. But we're going to have a look at this diagram between male and female and just see what is listed as the top cause. So as you see on the left-hand side with males, BPH and UTI, and along with it, urological malignancies are actually quite common that can present with these symptoms. We do see detrusor muscle weakness from time to time, and not so much chronic prostatitis. And urethral strictures just falls down the list. And certainly in terms of neurological presentations, we don't see that very often because St George itself is not a spinal center. So some of these patients normally get seen a lot more either Randwick, Prince of Wales, or alternatively where the spinal centre is at Royal North Shore. For women, most of the time we encounter urinary tract infections, but also malignancy and detrusor muscle weakness, and to an extent in women we will see pelvic organ prolapse and also a lot more of stress urinary incontinence or just urinary incontinence in general. So if you're looking at men, so storage symptoms, so those are the ones that actually have frequency, urgency, nocturia. They're mostly associated with UTI, bladder stones, urothelial carcinomas, and overactive bladder symptoms. Now, if they're having obstructive symptoms, then usually it is something that's obstructing them at the outlet, and that can be from an enlarged prostate, or you have a contracture, or there is a stricture, or alternatively, a similar sort of presentation can arise if you don't actually have good contraction of the detrusor muscle. So in that situation, we call that condition detrusor underactivity, and that particular problem can only be sort of assessed by urodynamics. So why do we bother about lower urinary tract symptoms? So in all of these epidemiological studies, it is actually very, very common. There's actually a big study from the Nordic states as well as from the Americas and US that suggests that at least half the population had experienced lower urinary tract symptoms, and up to 76% of the patients actually has to wake up and pass urine, so that's nocturia. Now, if you look at the differential between men and women, women complain more of storage symptoms, and the men is the other way around. Also, as we age, urinary incontinence also increases in prevalence, especially in women. And overactive bladder symptoms are actually very prevalent. Up to 25% of the population in men and women actually can get OAB symptoms. So unfortunately, the urinary tract is not very kind to us as we age. And if you actually look at the statistics that has been put forward from the Continence Foundation of Australia, you can see that as we age with time, the curve rises exponentially. And so over a predicted 15-year period, we will double our incontinence rates. So this is actually a significant burden on society, and we have to address this at some point. And looking at the prevalence for BPH, as we age as well, the prevalence rises. So in those men who are between the age of 70 to 79, there's at least a 45% incidence or prevalence of lower urinary tract symptoms in that regard. And why do we see these changes? And mainly is because as we age and the exposure of testosterone gets longer, then the prostate responds and actually overgrows and becomes enlarged. And depending on where it enlarges, then you would actually get the outlet obstruction symptoms. So that's briefly about prevalence. So what about clinical features? How do we actually work up these patients? Well, as with any condition, we start off with a very thorough history and examination. So when you're actually looking to elicit the symptoms, you have to sort of clarify the exact nature of the LUTS, whether it be storage or voiding symptoms or both, because often it's not one or the other. They actually can sort of be collective together. And also some of the other symptoms that are actually quite alarming, for example, hematuria, pain, and in particular also the medication history. Often than not, I've had patients that have been referred who have frequency urgency, but if you take a proper history, you'll find that they're actually on diuretics, and that could be, that was the reason they actually has that problem. In terms of examination, it is quite limited. For men in particular, we obviously will be doing a DRE exam, and then women will be doing a pelvic exam. So I guess it really depends on your interest in this particular field. Now, is there a questionnaire that we use to actually quantify the severity? Yes, there is. And for men, it is what we call the International Prostate Symptom Score. And so you can actually have that as a pamphlet, which the patients can fill in when they're waiting to be called to be seen. It is not particularly onerous. There's only 7 questions, but it is actually helpful if you want to actually objectify, the complaint. So this is actually the IPSS. So it has 7 domains, and it's a score out of 35. And then we sort of stratify it between mild, moderate to severe, depending on what scoring system they get. And then we ask an overall most bothered kind of symptom that they're encountering, and also, you know, are they happy or feeling terrible about their urinary symptoms. So this is actually quite a good thing, because not only does it give you a baseline, but as you're initiating treatment, you can actually sort of objectively quantify whether they're actually getting better or not. So if we're just looking at storage and filling symptoms, and in particular in women, so what are some of the things that we actually encounter most often? I think UTI is definitely the top of your diagnosis. And second would be overactive bladder symptoms. Now that can be with or without incontinence. So urinary incontinence itself has different types. So stress urinary incontinence is the one where you cough and sneeze and you leak urine. Urge is when you have the urge to go and you can't make it. That's when it actually leaks urine. Overflow incontinence just means that the bladder is chronically obstructed, and then it just trickles out when the pressure is sort of exceeded. And oftentimes you can have both mixed urinary incontinence. Now, interstitial cystitis is actually a very difficult entity to actually go through in a talk. However, I have actually listed some slides later on, and we'll go through a little bit about what that is. But also in this post-menopausal group, that is also quite important, because that's when we actually see the most amount of problems. Also be mindful that, you know, bladder tumors and bladder stones can often present this way, and also pelvic organ prolapse. If we take the time to actually investigate and examine properly, sometimes you'd be surprised that prolapse is actually often found. When it comes to voiding symptoms in women, I think by and large in my practice, it is because the women have actually had a weakened detrusor muscle function. And so they can't actually empty out that urine, and hence they're actually complaining of slow stream and inability to actually empty out completely. Now, obviously there are other causes that can actually precipitate this, and that's obviously, you know, retention. When somebody has retention, especially in women, I think, you know, even though there's listings of stricture disease or diverticulums, they're quite rare. Most of the time I see them actually having constipation, and that's actually the cause of their retention episode. So the bowel function and urinary function are actually very together in that sense, because they share a common pathway with their nervous innervation. There is also a particular entity called urethral syndrome, which is also very difficult to sort of treat, but that usually has a predominant dysuria kind of component, but also a feeling of frequency and incomplete emptying. And as you can see, urethral syndrome it crosses both voiding and storage symptoms. As I said, stress urinary incontinence is when you leak urine when you cough or sneeze, and usually there are also pelvic organ prolapse that actually can be evident at the same time. So this is actually quite important when you're sort of bracketing, you know, your symptomatology, that you sort of think about what I said to you about the listing of etiologies. What about side effects with medication? So I think that's actually definitely very, very important to know. So I think in your history taking, you know, make sure you directed questions in asking about whether they take diuretics, lithium, which is because it can cause detrusor insipidus. Any of the anticholinergic medications can actually partially compromise bladder function. So if they're already sort of weak in that sense, then they will get the storage symptoms, the voiding symptoms, and that's, you know, urinary retention-like symptoms. Alpha blockers, if you are taking like Sudafed all the time, that can actually also manifest that way. And also this particular entity about polyuria, I think I'm seeing it more and more, and that is because, you know, we are underdiagnosing diabetes insipidus, but also a lot of diabetes are not treated optimally, so they get galactosuria. And oftentimes, you know, when they have chronic kidney disease, the kidney can't retain the fluid, and hence it gets pushed out as urine, and then they get this polyuric effect. All right, so as I said to you, this is a summary. Lower urinary tract symptoms, you know, in terms of physical examination, we obviously look at the height and weight, looking to see whether there is a presence of a bladder fullness. And also, I'm not so much sort of concerned about neurologic examination, because that's obviously quite directed in terms of pathology. But if there was a patient that tells you that they've got increasing difficulty emptying their bladder, and also they can't feel their, you know, their when they actually wipe themselves with bowel movements, then you're going to be very alert, because sometimes that can be an evolving spinal cord compression issue. And in terms of the pelvic exam, I guess this is kind of disadvantages some of the male GPs that are working, because they may not be so comfortable doing pelvic examinations to look for pelvic organ prolapse or assessing for stress urinary incontinence. Also, I mean, obviously for men, I've had a fair group of GPs who are quite dedicated in doing DRE exams, so that's actually quite good. But irrespective, we will do it again at our clinic anyways. But that's obviously actually very good to actually assess the anal tone as well as the prostate, if it's enlarged or not. The standing stress test, I think sometimes people do it, and that's basically just getting to stand and either to Valsalva or to cough and see whether they leak urine. So that's actually a very crude way of diagnosing stress urinary incontinence. And what about the investigation? So you've gone through history, you've gone through exams, you know, and in your 6 minutes, what can you actually drum up to actually investigate them with? So most of the time, you guys don't have a bladder scan, but I think it'll be worthwhile thinking about getting one, because first of all, it's rebatable, and secondly, for each individual scan you do, if you do have a nurse that's actually in your practice, it often helps you actually to sort of differentiate between the lower urinary tract symptoms. I think urinalysis is a must, and if that was abnormal, then you will send them off for a routine MSU. Routine blood tests we tend not to do unless you suspect that there is an underlying kidney problem. PSA we do all the time, obviously, because I have a vested interest in that. But avoiding diarrhea is also something that's very important, and that will pick up more importantly than the polyuric patients, because you can see what happens as they're avoiding during the day and night and what their intake is. So if they're actually urinating more volume during the nighttime than they are during the day, then you know that you've got nocturnal polyuria. And so you can be more directed in terms of your treatment. But these are just the basic accessible investigations that I would actually recommend to your patients and when you see them. But what about the specialist investigations? Obviously, that's something different. I think renal tract ultrasound, you can actually organize that if you feel there was a need to, especially I think if they've got hematuria or pain and you want to rule out stones. But obviously for something as specialized as urodynamics and cystoscopy, we would get to see them first. And obviously we would be directing them depending on what the complexity of the case is. So down the bottom here where you see this is actually the urodynamic setup where the chairs are. And then this is the tracings of urodynamics. So urodynamics is actually a very good functional test that we utilize to actually assess what happens as we push water into the bladder and the patient gets full, and then what happens when they're trying to empty. So we can see the pressure differentials and work out a differential diagnosis for the patients. So what about the reasons in general to refer? So I think first of all, if you're investigating and you've done everything right and you can't find a cause and the patient is still bothered, I think that's a good reason to refer. Obviously, if you've initiated initial therapies and they're not getting any better, that's definitely another reason. And without saying, hematuria obviously is very important. And anybody that you don't feel comfortable with, I think, you know, it'd be not wrong to say that you should refer onwards, especially if they have genital prolapse. And if you do have a flow machine, they have really abnormal PVR. Now, that is actually quite a difficult kind of numerical number that you assign to say what is abnormal PVR. So some people can have like, you know, avoided volume of 110 and have a residual of 30, but is that significant? Usually not. So for us, if the residual volume is not more than 100, then technically we don't feel that it is that abnormal. And obviously, if the patient, you know, has concerns or is distressed about their symptoms and you can't work out the answer, then I think, you know, it'd be right to actually just refer them on. So I think these are the basic reasons to actually refer. And what about the general management in terms of what we see with lower urinary tract symptoms? I think if you look at across the board, you can just give them these particular helpful aids. First of all, if they're drinking too much caffeine, you can cut them back. Usually I would just say, you know, cut to half, maximum 2 caffeine beverages if they are drinking more than that. Use cranberry tablets if they have a problem with UTIs rather than juice, because the juice is too sweet and it doesn't have enough concentration for the ingredients that actually keeps the urinary tract healthy. In particular in women, you know, I see a bimodal distribution in terms of recurrent UTIs, the ones that are actually very young, that are sexually active, and then the menopausal women who are getting it more and more. So I think if it becomes an issue, you know, after intercourse, as the initiator, you can actually get them to pee after sexual activity, and sometimes even institute post-coital prophylaxis. For genital prolapse, you can obviously, and actually stress urinary incontinence for that matter, you can actually direct them to doing pelvic floor exercises. And that's quite common. Pelvic floor exercises are the same as what they call Kegel exercises. And it's a series of contractions of the pelvic floor that can do to strengthen it. Now, if a patient presents to you and they're not really a surgical candidate, they're quite crumbly, I think you can refer them on to actually insert a pessary that can actually reduce the prolapse. If for anybody who actually has stress urinary incontinence and their BMI is over 30, it is encouraged that they should lose weight, because that actually has been demonstrably helpful in clinical papers to decrease the amount of stress incontinence and bother. If somebody presents to you with frequency urgency and they don't actually have prolapse or infection, then I think it'd be worthwhile to tell them to do bladder drills. So that's like a series of behavioral techniques that, you know, if they have urgency, just don't give in and pee. Get them to be distracted or do something, or think about not, you know, water related kind of events. So these things are helpful. Or in particular, if you've got patients who are leaking excessively, you know, you can direct them to actually see websites where they can get, you know, subsidized costs for their pad use, etc. So there is actually, the Continence Foundation of Australia actually has a dedicated website subpage that can offer patients who meet the criteria to be subsidized for their pad purchases. What about drug-wise? Obviously, with UTI, you treat it according to the sensitivities. Now, for OAB symptoms, you know, we used to dispense Ditropan or Oxytrol patches, but we're seeing that there's a problem with this, because with long-term usage, it can actually worsen cognitive function. And so you will see that now a lot of the pharmaceutical companies don't push drugs like Vesicare very much anymore, because they're aware of this. And actually, that's very important to know. Now, the new medication, Betmega, which it's mirabegron, that's a different way of actually tackling overactive bladder symptoms. And that actually can be used instead of antimuscarinics. But because it works in a different way, it tends to affect the cardiovascular system, and you have to monitor their blood pressure. You can use Botox certainly for OAB symptoms, and I'll chat to you a little bit about that later. Now, for the tricyclic antidepressants, that is actually a reasonable medication to use for somebody who has nocturia or even nocturnal enuresis, because you know, when you use amitriptyline, that's what they used to use for kids when they had bedwetting events at night. Certainly, I think for women who are actually sexually active and have recurrent UTIs, it would be a good idea to actually offer them Ovestin, a topical estrogen. I think it's, even if somebody has a breast cancer history, topical estrogen is not so much contraindicated as HRT is. And if they actually do have diabetes insipidus or nocturnal polyuria, then certainly you can give things like desmopressin, which is called Minorin. It comes in a wafer form. They actually just put under the tongue and they just melt. So this can actually be used, but got to be very careful to monitor their sodium levels, because it can cause hyponatremia. And eventually surgery, depending on what the medical condition is, whether it be stress urinary incontinence, then we can do either bulking agents or sling procedures. So all of these I'm just listing in particular, but we'll go through them as we go through each individual pathology. For males, that's a little bit different, obviously. You know, the most common drugs that we dispense these days, if we think that is a prostate problem, is Flowmaxtra. Usually we don't use Minipress very often, even though it's cheap, just because it's not very uroselective. We do combination therapy with Duodart, And I'm not sure whether you do know that these days you don't need the urologist to initiate the treatments. You can actually dispense an authority script for the patients on spec from the GP practice without going through us. Obviously, if that doesn't work, then obviously there is surgical options, of which now there is a plethora of what we call MIST. So MIST is a new terminology, and it stands for minimally invasive surgical therapy for BPH. And we'll go through that in a little while as well. So this is actually quite a good summary of all of the medications that we actually have available to Australian population, and whether they're listed as PBS or otherwise, it's all there. But I've obviously highlighted the ones that we use quite often, which is tamsulosin, which is Flomaxtra. And as you can see, because it's not on the PBS schedule, you know, it can cost up to $60 for the patients to actually be on them. So that's actually quite an expensive drug. Now, silodosin, which is Urorec, it's half the price. And I think you can use that in its stead if the patient is particularly cost sensitive. But tamsulosin with dutasteride, which is duodide, obviously it's on authority scripts, so there's no issue there in dispensing it, provided they obviously have a healthcare card. But I think in these medications, you know, obviously have to counsel them about retrograde ejaculation, postural hypotension, and in particular with duodide, if they're sexually active, it's quite a significant cause of sexual dysfunction. So I think before you just willy-nilly just dispense these medications, you might have to talk to them whether it will bother them if they actually lose sexual libido or have worsening erectile dysfunction. The other concern about duodide, you may have heard, is, you know, whether it increases your risk of prostate cancer, and the jury is definitely out. It doesn't. So it's actually quite safe. So I think I'm going to focus a little bit more about male treatments for this section. But before I move on into a little bit more specifics, is there any questions from the panel that wish to ask me before I move on?
Hello.
All right.
Sorry, I was on mute. There are no questions yet, Dominic. I have one quick question while we're on that. When you're assessing an enlarged prostate, is there much value in doing an ultrasound of the prostate?
Well, yes. I think
that fits in with our diagnosis.
I think there is, because the ultrasound by default can act as your uroflow measure, because it will tell you how much they've voided, you know, and because, you know, when you go to do a renal tract ultrasound, they drink about a liter, and then they actually hold their bladder, they get scanned, and then they were asked to go to wee and then come back and rescan. And so that will tell you, you know, whether the bladder function is compromised. And also it can actually tell you whether there's actually complications arising from obstruction, for example, hydronephrosis, hydroureter, or whether they actually have bladder stones as a complication as well. So it is quite helpful as a non-invasive tool to actually guide you in regards to whether you think there is a problem.
Yeah.
But definitely, yeah.
Yeah. Okay. Thank you. Yeah, there's no other questions at this stage, so we'll push on, and yeah, be great.
So I think so the presentation, I've deliberately left out a lot of words because I'm talking a lot already. But in terms of just, you know, populating the whole slide with written material is quite hard to follow. So I'm just going to go through them pictorially and just sort of, you know, talk through these procedures. So what I'm showing you now is the TURP procedure, which is transurethral resection of prostate. This is by and large the most common surgery that we do, and at the moment in the public hospital, it is the only option we have to give to our patients. In a private setting, that's obviously different. But as you can see on your left-hand side picture, this is actually prostatic lobes that are actually compressing on the urethra, and that's why patients get obstructive symptoms, you know, because they've got a higher resistance to actually push the urine through, so they're going to get a slow flow. And if it's actually significant enough, they actually can't feel that they're emptying all the time. They can't feel that they're emptying. And obviously, depending on the degree of obstruction, you know, you have that intermittency where they pee a while and they stop, they pee a while and they stop. So that's actually quite a common presentation. And what we've done is actually channeled the prostate. So we've actually used thermal energy to cut away some of the prostate tissue and actually let the bladder drain better. Now, obviously, this particular procedure has to be done well because there are certain complications. So usually with the TURP procedure, you would 9 out of 10 times not have any ejaculation. So that's the biggest thing that we need to ask our patients, because if it bothers them, then we can't offer this treatment to them. The other problem is if you cut too much downwards, then sometimes it can injure the sphincter, and then the patients actually get stress incontinence. So you've got to have to tell them that, you know, these are material risks, although they're not very often that do happen, but if it did happen, then at least we're aware of it. But definitely, you know, an ejaculation or a retrograded no ejaculation is actually quite common. And then there are also a variation of doing a TURP. So you can actually use laser because, as I said, we're trying to create a cavity within the prostate to facilitate flow. So you can either chisel out the prostate by cutting through, or you can actually use various lasers. And so the lasers depends on the technique. So you obviously heard about green light lasers. Now, green light just vaporizes. So you just constantly vaporize the prostate so that you can get a cavity. Other lasers like HOLEP, holmium lasers, they actually are like almost like doing an endoscopic way of an open prostatectomy, because you find a plane between the compressed capsule and the adenoma, and then you peel them off, and then you push that whole adenoma into the bladder, and then you morcellate them out later on. But the laser, its selling point is because it can control bleeding much better than the TURP. So most patients who are on anticoagulations, technically speaking, don't have to stop them, but we do encourage them to be stopped just because you do run into trouble occasionally when you offer them laser therapy and they can still bleed. So you wouldn't want to take that chance. This is an example of a holmium laser. As I said to you, depending on what laser type you use, you can do different things. So the holmium laser has very shallow depth, so it's not going to burn and necrose your tissue. All it does is create a plane for you to actually get the adenoma separated away from the compressed capsule, and that opens up the channel for you. So if you look at it the other way around, so yes, you can see, we use the laser to actually get between the enlarged prostate and the capsule, and then just morcellate the pieces when they're actually inside the bladder here. So what about the outcomes? So whether you're doing a TURP or HOLEP, the outcome is similar. It is very effective. So 9 out of 10 times your patients will benefit from the procedure, and to an extent, it is the gold standard to which all subsequent new therapies are compared against. Obviously, this is not comparing apples to oranges, but therefore, for the purposes of a definitive standard of care, everything has to be compared to it. And basically, what do we see in terms of assessing patients who are improved? Obviously, we see a reduction in that IPSS score. As you can see here, it's minusing, which is good because you're obviously reducing the severity. And also their Qmax goes up, so the flow rate gets better. And obviously you want to see that their residual volume goes down. So these are all positives in terms of addressing the patient's complaints. But are there any alternatives? As I said to you before, yes, we are actually in the very exciting stages of discovering more and more minimally invasive surgical treatments. So the UroLift, I'm pretty sure you've heard about it. There is 7-year data on this particular procedure. How is it done? Basically, it is a minimally invasive day surgical procedure, and it's done via cystoscopy. So all you do is when they're under anesthetic, and in the Americas, they tend to do this under local because it's all about remuneration for the Americans. And if you do any office-based procedures, they get paid better than if you actually take them to theatre. And it's the other way around for us here, which is kind of sad. What happens is when you actually introduce a catheter, there is actually a particular, the UroLift device. It actually has a staple that is actually inside it. And so as you actually compress the prostate to one side, you deploy that staple and it will just bind the staple to the prostate and pull it apart on one side. And if you repeat it for the other side, then it does the same thing. And what happens is essentially you are using mechanical tension to pull the prostate apart from one another, so the channel inside becomes opened. So this is actually a very quick procedure. Most of the time we do about, we do this in about 10 minutes and it's all game over. So it does open up the urethra. The only problem, it doesn't really remove the tissues because it's only using mechanical tension, but it is safe. And virtually, I've not had anybody that actually complained of sexual dysfunction. So you don't interrupt their erectile dysfunction and they don't complain of retrograde ejaculation because you haven't actually opened up the bladder neck area. So they can still close when they have and retain antegrade ejaculation. So this is how we do it. That's the device there. So how many implants do we put in? So as many as we need to actually get the lumen to be opened. And you can see here, that's actually the device. And then as we're pushing the prostate to one side, then we will fire the staple and it will just capture and pull the prostate to one side. So it's actually quite a simple procedure. As I said, there is criteria for use. So technically speaking, we try to address patients who have less than 80 cc's of prostate enlargement. So that's when the ultrasound comes in handy. And also preferably no median lobes because we can't actually use, we can't actually deploy the sutures to actually capture those. It does have some artifacts when you're trying to investigate patients who have high PSA with an MRI scan, but if with a trained eye, as always, they can always look past that and actually just give you accurate reporting when you're assessing for, Pyrex lesions on MRI scan. So how effective it is, you can see that within 3 months of treatment compared to a sham placebo, there is a huge difference that is statistically significant in terms of their score. So there is a significant reduction in their symptomatology as well as an increase in their flow rate. So it is actually very, very effective. What is a success? 85%, and that's up to 5 years. In their longer term data, that dropped off a little bit, but not too bad. So overall, I think you would push to say that if you want to use UroLift in the right and appropriate kind of selected patient, you get an 80% success outcome. So the next one is Resume. So Resume is actually an interesting technology as well. What it does is using very small droplets of sterile water that is churned through this particular device here that gets heated up. And once it's heated up, when you introduce this particular needle into the adenoma, it just disperses vapor. And that steam is very, very hot. What it does is actually just cooks the prostate. And when it cooks the prostate, eventually what it does, it encourages apoptosis and it will shrink it away. So this is actually also very fast and you can actually use this to great effect. So if you can see right here, what happens is as you actually introduce, the technology, it just shrinks the prostate volume, but it takes up to 3 months. So when you talk to these patients, you have to counsel them that the effect is not immediate. And the one thing that's quite ironic about this treatment is when you actually do it, most of the time you need to put a catheter because when you introduce steam, it will swell before it dissipates, so they will be obstructed. Normally, we would counsel them that it takes up to 3 weeks for the catheter to be taken out successfully, where they can initiate spontaneous void. So that's something that they can put them off. This is what happens. You see before therapy, during therapy, and after therapy. That's the progression over 3 months. You want to come to a situation where the adenoma has contracted and the tube is opened. So if you actually compare UroLift with Resume, they're normally quite equivocal in terms of addressing the flow, but the problem is, as you can see with Resume, there's a higher need for catheterization and the retention risk is much higher. There's also slightly more sexual dysfunction within the resume group, whereas you don't see any ejaculatory dysfunction with UroLift, you see it in about 5% with the resume. So it's not entirely safe if they want absolute no, interruption in terms of their sexual function. So what's the summary? Just to encourage to say that UroLift and resume have similar efficacy, but it's just that the way it does it is a little bit different, and the UroLift has obviously a much lower need for catheterization. In terms of how long it lasts, the resume only has 5-year data and is comparable between the two. So if you're looking to see overall for BPH what you can offer the patients, then certainly there are certain tick boxes. So as you can see, TURPs by and large ticks all of the boxes along with the lasers, and the resumes you have to be a little bit selective, similarly with the UroLift as well. So I think the key is to obtain good success, you have to sort of be selective about your criteria to actually deliver these treatment options. That's actually another summary about the ablation techniques. All right. So the other, sorry, yes,
Dominic,
question.
There are a couple of questions about UroLift.
Yes.
And those things. So someone's asking, like, do the staples ever come loose or cause too much tension and bleeding or hematoma within the prostate?
No. So it's unusual to actually get a hematoma because the staple is actually very small. So it just punctures enough to actually go through the prostate and then goes through the other side of the capsule and holds. So basically, you don't normally get a hematoma, but because the prostate can be quite vascular on the surface, you can actually obviously traumatize those vessels and they can bleed to the point where you might need to put a catheter temporarily. Yeah.
And the UroLift stays there forever. Can it ever be removed or?
Yes. So for example, if they fail therapy, then you can sort of offer them TURP procedure. And so when you're actually cutting using the loop, you can cut through the sutures. But the sutures are nitinol sutures, so they actually are not going to dissolve. There's no point otherwise if they dissolve, because then you have a relapse of the obstruction. So these inert, non-dissolving sutures that they actually use.
Right. Okay. Well,
Yeah.
and it's been used for 7 years, you were saying.
Sorry.
So there are only 7 years of data on the UroLift, or have men had it for 15, 20 years, or?
No. Well, this particular device has only been available for the last 7 years. Yeah.
Yeah.
Well, 8 years now, because the 7-year data came out last year.
Yeah. Someone I think spotted on one of your charts asked a question: was there more urethral stricture after the laser as opposed to a traditional TURP? I'm not sure if on one of your tables it might have been a table about incidence of stricture after laser TURP versus traditional TURP.
The answer is depending on what laser you use, it's actually safer, because when you actually introduce the laser probe, it's not so big, and so you don't tend to traumatize. So I think you get a higher stricture rate with a TURP procedure, just because there is a lot of in and out, because when you actually resect, the bladder gets fuller, and then you have to empty the bladder. So the scope tends to move all the time. Whereas with the laser, you're pointing at it and you're just moving your scope very gently. So you tend to be less traumatic, unless obviously you're not very cautious, and obviously the laser gets, it slips beyond where you need it to be, and you've actually accidentally sort of injured the normal tissue where you would normally laser anyways. So that could be, but by and large, once you're trained up to actually use a laser, you tend to see less urethral strictures.
Okay, thanks, Dominic. Yeah, we'll move on. Yeah, that's enough for now. Thanks.
Yep. So I think you might have just seen a newspaper clipping recently about this iTind implant device. So basically, this is the next new tool on the block that is currently undergoing TGA approval. Basically, it's a promising treatment in the sense that you put this little gadget into the prostate and you leave it there for 5 to 7 days. So what happens is it actually just opens up and causes pressure necrosis. And then after a week later, you just remove that particular device and it will just keep the prostate open. So that's actually being trialed at the moment in some of the hospitals, particularly in the SAN. And so we don't actually have the data available for Australian population, but definitely this has been introduced already to the European market, and it seems to be working quite well. And as you can see, you know, the score decreases with time and your flow rate increases with time. So this is actually something to watch. We don't actually have this available at the moment, but this is another challenge. I mean, not another alternative to treatment for BPH. So all very exciting kind of technologies that are coming out. So what happens if you don't treat obstruction? I think just to be aware of the fact you can get bladder calculus, you can get overflow incontinence, and then eventually even renal failure, as I said to you before, if the pressure is so significant within the prostate, within the bladder, that you have retrograde reflux up to the kidneys. So usually if you have some patients who actually have high post-void residual, that's actually a indication for us to actually surgically manage the patient. All right, moving forward. So we've talked about, obstruction in men. Now we're going to talk about overactive bladder symptoms. So also, this is actually a syndrome. So basically, it's not where you can hang a sign on. Basically, you're eliciting the symptoms. And basically, there are 3 symptoms. Fun. I mean, obviously, no fun for the patient. But frequency, urgency, nocturia. And that is with or without incontinence. So this particular 3 complex symptoms can actually be very devastating for the patient. I mean, you hear of like examples where patients actually get chained to the bathroom. Every time that they go out, they have to know where the bathrooms are. Otherwise, they're afraid to go out, and it sort of impedes their quality of life. So this is actually a very common syndrome, and it's predominantly based on your symptoms, not on any signs. It is very, very frequent. It is, as I said to you before, there's about a 25% incidence of this particular entity in men and women, and in particular in women, because the urethra is shorter, then they tend to have more incontinent episodes. Now, when we're talking about these particular symptoms, we just need to know that frequency that's up to 8 times a day is actually quite normal. So when we say that excessive frequency is when they pee more than 8 times during the day. And urgency is obviously that feeling that you need to wee, but you can't defer it. Otherwise, you feel that you're going to lose the volume, yeah? So, as I said, you just have to maintain healthy habits and bladder drills. But often this is quite hard because most of the time the patient's already worked out, that they won't drink anything that's going to worsen their symptoms. So, they're not silly, that they've done something themselves and they come to you because they can't get better. So what do you do in that situations when you've sort of done the normal, general advice kind of treatment options? Well, as I said to you before, medical therapy with antimuscarinics, but obviously there's a problem not only with cognition, but then you get the patients complaining of dry eyes and dry mouth and constipation. And that's all of the patients, all of the medications that are available, whether it be Vesicare, Ditropan, Oxytrol, all of them have that kind of side effect. Even though it's selective for the urinary tract, there will always be some that will escape. So you've got to be obviously, tell your patients about that. So we'll go through that. And then and the other medication right now that we've actually got is Betmega. So Betmega works, I'll go through these in a moment, in a different way. So whereas the antimuscarinic targets the acetylcholine pathway, the Betmega targets the beta-3 adrenoceptors. So this is an antagonist, so this is an agonist. So what it does is once it latches onto here, it just paralyzes the muscle, and hence you don't want to pee so often. So that's the difference between the two. And obviously because it's not targeting the muscarinic receptors, you don't have the dry eyes, dry mouth, although it does have cardiovascular side effects. And can you use them both together? Yes, you can. It's very expensive though, because the Betmega will set you back about $50 a month. And if you actually have it with Vesicare, that'd be another $50. So $100 a month is probably quite a lot for somebody, who you sort of normally treat in the elderly population. So this is just a run through about all the available antimuscarinics. I think I have it in a different slide, but Oxytrol is a better option than Ditropan. And do you know why it's called Ditropan? So it is actually a nanogram for not a drip. So, you know, when you're on oxytrypan, you shouldn't be dripping any urine. That's why it's called that. Currently, Vesicare is still not on the PBS scheme, so they have to pay full price for it. What about the surgical options if you fail medical therapy? So one thing that we can offer them is actually sacral neuromodulation. So this is actually a pacemaker generally that you actually put in for the patient. And it's quite an easy procedure. You can see that that's the pacemaker here. And there is actually a electrical cord that is put through the back percutaneously. And this particular wire sits alongside the S3 nerve, which is the nerve that controls the bladder. So the disadvantage of this currently is this is not MRI compatible. So if you actually put it in and the patient needs an MRI, you have to take it out. Otherwise, it can cause problems. And it's expensive, but we can offer it at St. George to the public patients. So it is not a concern to us. So, you know, we don't have to have them insured to actually give or deliver this therapy to them. What's the advantage? If it works, it will work until the life of the battery, which currently is not rechargeable. So up to 7 years. So all they do is if the symptoms relapses and when the battery runs out, we just replace a new one. And that's actually quite a small procedure. As opposed to Botox injections. So Botox injections, you know, it does the same thing, but in smooth muscles, it lasts longer. So what we aim to do is actually inject Botox in small amounts throughout the entire bladder, just to paralyze the bladder so that it can actually stretch a bit more. Because Botox essentially targets the nerves, so not only will the motor nerves be affected, but the sensory nerves will be affected as well. So you have a combination where the bladder can be relaxed and they can actually stretch, but also that frequency and urgency symptoms tends to dissipate because it is targeting the nervous system. The only problem with this is it doesn't last. So on average, when we actually do Botox injections, it lasts on average about 9 months, and you have to do it again. And also you run the risks of urinary retention because it is a paralytic agent and it's the most potent biological toxin we have known to mankind, sorry. So there is that small risk, but what is that risk? About 6%. So you would counsel your patients that before they undertake Botox, that, you know, there may be a slight chance that they need a catheter temporarily, but it's not like they catheter 6 times a day. You might just be required to catheterize once a day for the first 2 weeks, for example. So nowadays, Botox injections is covered by Medicare. So the patient doesn't actually have to pay $600 out of pocket to buy a vial of Botox. So the other thing that we do have offer is also this particular treatment called PTNS. So it's the posterior tibial nerve stimulation. So it's basically like acupuncture, except that when you put the needle in, you have to attach it to a device like this that sends electrical signals. And the reason why we actually target the posterior tibial nerve is it connects upstream to S3. And so you can get indirectly effects on the bladder. So basically, this is a little bit more intensive because we have to see the patients every week for 3 months before they actually get better. And once they actually get better, then you can maintain them by just doing these treatments 3 times in every 6 months. So it's actually quite good that it's minimally invasive. Unfortunately, at the moment, they're trying to launch a product where you can actually just insert a chip there that constantly does the job so they don't have to come back for repeated visits, but that's not available as yet. So this is actually just a little bit about treatment algorithms for overactive bladder. You know, what you've instituted. If they don't work, then obviously you have to sort of refer them on where we can actually offer them all the other treatments options. Now, one question or one rather point, augmentation cystoplasty. With the introduction of Botox injections, we hardly do this anymore. I think within the 5-year history at St. George Hospital, there may have been 1 case that was done, whereas it was quite common previously. So this is just a quick summary about what we can offer, from medications to Botox to sacral neuromodulation for overactive bladder symptoms. So just something for you to just have a quick glance at if you're just wanting to sort of tell your patients what's available out there. So that's actually OAB in a nutshell. Any questions?
One question, just going over again with the Vesicare and
Yep.
the Ditroband, VCK, Betmega. Given what you've said, do you just prescribe Betmega first up? Is that just the first place to go, do you think, or should we be trying the others?
Well, there's always, I mean, like, I think the cost is the problem. So normally with us, we get samples, and I think you can request samples from the pharmaceutical companies as well. You know, after a packet of, you know, trial of 10, you'd know whether it works or it doesn't. So what I normally do is I give them a trial packet and I give them a script, and I say, after 10 days, if it works for you, you can fill the script. Obviously, you know, you obviously tell them that it's going to cost them, you know, a bit of money. And most of the time, if you explain it to them that, you know, there's got no side effects from, you know, dry eyes and dry mouth, that they're quite eager to try it out. But I will say to them, if you, after 10 days, if it doesn't work, just don't bother, and then, you know, we can try something else. And that's when I would actually introduce Oxytrol, because it's cheaper.
Okay. Yeah.
Mm.
And just really quickly, just while it's on the page here, so someone just asked about prostate artery embolization for BPH.
Yeah.
You have a quick comment on it?
Yeah, I haven't actually included that because that's actually a very controversial treatment option. So those are the ones that we really reserve for patients who are actually very high risk, anesthetically speaking. But there is a trial that's going on at the moment, but St. George is not one of the trial centers. It is having some effect, especially in large vascular prostates, but it is quite invasive, and it takes sometimes, it has taken, you know, our interventional radiologists up to 3 hours to do an embolization. So it's not really that quick either. So you've got to have to sort of temper our enthusiasm in that regard until data comes out. But yes, we do offer it in exceptional circumstances. I think in the past year, we've done 3.
Right. Okay. Thanks, Dominic. Yes.
No worries. All right, well, the next thing is stress urinary incontinence. Obviously, this is actually more focused in females because men, we don't see it very often, unless obviously it's in a population where the patient has had radical prostatectomy. And that's actually a different sort of entity altogether. So what is urinary incontinence or stress urinary incontinence? So the definition is just involuntary loss of urine when the, hang on, that's actually, is that right? Is that involuntary loss of urine? Yeah, when you cough, sneeze, or raise your abdominal pressure. So it's not, you know, obviously mental stress, it's physical stress. And it can actually be quite debilitating, you know, because if you're constantly trying to exercise to lose weight, and most of the time, you know, women who actually are heavier run into a lot more trouble because their self-esteem is low, because they want to keep the weight off, they can't, because they can't exercise, because, you know, they keep losing urine, and it actually becomes a vicious cycle. And it's a terrible thing to see for something so treatable to actually have them think that there's no hope out there. So as I said, as we age, the prevalence is only going to get worse. And you can see a lot more of these patients, especially in nursing home environments. As I said, you know, there's certain stigma attached to it, and certainly, you know, a lot of mental health issues that's associated with it. Not to mention, you know, excessive costs from using just pads all the time. So obviously, as I said, you know, it affects women more than men, but it's a highly prevalent issue, and it's costs, you know, the Australian health probably up to like 1.2 billion a year in terms of just loss in productivity. What are the risk factors? Unfortunately, aging is one of them. Menopause is one of them. As I said, obesity is one of them. Obviously, if you've had children, that's also a problem. You know, you can even see this in nulliparous women, like, you know, because it's not sort of that they're immune to it. There's, to an extent, obviously a genetic component, and it's more in the Caucasian population, less seen in African Americans, really. And also pelvic organ prolapse is usually also quite evident as well when you actually see, and I'll show you a slide later on why that is, because the whole genital urinary tract and the female are all connected with different ligaments altogether. So if one level fails, then the other levels will fail as well. So what are the treatment options? Obviously, as I said, try to lose the weight, especially you know, if they're BMI more than 30. Pelvic floor exercise is very important. You would really need to emphasize on that. and they have to do it for at least 3 months before they actually see any benefits. Now, medications we don't have available in Australia that's actually targeted, but in Europe you can use duloxetine, which is obviously a SNRI, and that's actually been used more widely in the European market, but we don't have TGA approval to use duloxetine to treat stress urinary incontinence in Australia. And obviously you can use urinary pessaries, so you can go and refer them on to the pelvic floor unit at St. George, and they can fit a pessary in, they can compress the urethra. Obviously that needs to be changed every 6 months or so. But if they're not really particularly liking that kind of non-invasive measure, then what is it that's available to them outside of that? So you can go from just injecting the urethra to bulk it up so that you can tighten out the urethra, or you can do the procedures, what we call Burge-Kolber suspensions, which, because of this mesh dilemma, is actually making a comeback. And that's a bit of a disadvantage to the gynecologists because they've been trained their entire careers to actually do mid-urethral slings. Now that all of a sudden we've taken that away, then they've got nothing to do, and they're not trained in doing autologous fascial slings. So they have to either relearn that procedure or actually go back and adopt, what they were taught before. So this is actually a problem that we're seeing more and more because as the mesh litigation expands and it's multi-billion-dollar kind of case lawsuits, then the device companies are all withdrawing their products. So Coloplast has advised us as of 1st of December that they will no longer sell any mesh-related implants in Australia and New Zealand. So these are the pessaries, as you can see. So they fit into the vagina, and that just pushes up on the urethra. And so obviously, depending on position, sometimes you can lose that kind of traction, and then they can leak some. But by and large, it is quite effective if they're not a suitable candidate, and particularly if they're not sexually active. I mean, I can't imagine trying to be sexually active with this thing in there. It's just impossible. But down the bottom here, we are also seeing some of the clinics offering laser therapy, not only for vaginal rejuvenation, but also to actually treat stress urinary incontinence. Now, that's actually very, very controversial right now because there's no trial data. So a lot of people are just marketing this to say that it is the next home run treatment, but it isn't. So I think you've got to be very careful before you push this, to your patients to say, go and source somebody who actually offers vaginal lasers because we haven't worked it out yet, and it hasn't actually been done in a randomized fashion. So what have I said? So pelvic floor training, pessaries, and the procedures. So I'll show you what these procedures are. So this is the Burge-Kolber suspension. So this is actually a tape, sorry. This is an autologous sling where you just sling it around the bladder neck area and you're trying to just kink it. Now you just have to know that sling surgeries by definition causes obstruction. It's just the degree of obstruction. That's how it works, whether it be when they say it's tension free, it still obstructs. So that's why you have people, when they've had a sling implanted, if it's too tight, then they get that voiding symptoms. They constantly have to go, they can't empty, and the stream is very slow. So that's the most commonest cause of obstruction in women, actually, sling being too tight. So this is what we're talking about when we talk about Burge suspension. So this is the urethra, and this is the bladder neck. So with this junction here, we're trying to suspend it to the pectineal ligament so that it creates the angle again, so that when the pressure rises within the bladder, you won't leak urine out. So that's what we call Burge-Kolber suspension. So it's been available since the 1960s. But obviously, because of the slings, it sort of went down in terms of popularity, but now it's swung back up again. And the other sort of, gold standard is this autologous sling. Now, it's not very popular because we have to make a separate incision to take the patient's fascia to actually do the sling. But now, because we don't actually have the mid-urethral sling available, we are doing more and more of this. And you don't necessarily have to take fascia from the tummy. You can take it from the fascia lata from your leg as well. But this is what I'm talking about. This particular surgery, the sling procedure, is no longer, or will be shortly, within the next couple of years, unavailable to Australian women. Okay, so that's actually stress urinary incontinence in women. Any questions?
No, we're all good. Yeah.
All right, so we move on to another problem, pelvic organ prolapse. So as you can see here, that's the poor turtle having a prolapse of the uterus. You never saw that, eh? So basically, what is pelvic organ prolapse? So pelvic organ prolapse is basically a hernia of the abdominal structures into the vagina. So the vagina is divided into 3 compartments. So you have the anterior compartment where the bladder sits, and then you have the posterior compartment where the rectum sits, and then you also have the vault or the cervix or the uterus. So that's what we call the apical component. So this is what we're talking about in terms of prolapse. So you can see a bulge coming through the vagina, so through the introitus. And if you look at the MRI study, that's what happens. It drops through the vagina, and that's what, and it presents itself. It's like a crowning from a baby. Now, interestingly, there was actually a study done when a gynecological clinic was just doing an epidemiological study, just doing pelvic examinations on all women that came through the clinic for whatever reason. And they found out that almost 60% of the women had significant prolapse, but they didn't have any symptoms. So it doesn't mean that if you've got prolapse, you have to fix it. So you only fix prolapse if it becomes a bother to them. So that's the take-home message for prolapse. So how often do you see this? Very often, 20 to 30% in multiparous women. Now, there's a question about whether if you do cesarean section that protects against women from getting prolapse. If you only have one child and you had your delivery with cesarean, yes, you do have a protection compared to vaginal births. But if you've had 2 or 3 children, it doesn't matter. You're at the same risk threshold as if you had spontaneous vaginal delivery. Whether hysterectomy actually worsens the structural ligaments and predisposes you to having prolapse, that is true. If you sort of do a hysterectomy, you often will actually not be protected, but you will obviously will weaken the pelvic floor, and you increase your risk of pelvic organ prolapse. And a 1 in 10 chance of needing surgery to address prolapse in a woman's lifetime. So quite a significant statistic, and it's quite a prevalent problem. So what is the workup? Usually they present with a vaginal bulge or pelvic pressure, but they also can have a problem with voiding and recurrent infections. Now, sometimes the lady will tell you, oh, how do you actually, sort of address the prolapse so that you won't get bothered? So they actually put their fingers into the vagina and either push up or push back, depending on which part is more component. That's called splinting the vagina. So if you actually can imagine, they put the finger up there and they push up, then you can reduce the bladder component, and then you can pee better. Obviously, they can actually get bowel movement symptoms as well, and most often times, they can actually get sexual dysfunction, increasing pain when they have intercourse, and also interferes with their orgasm, or nothing. Sometimes, as I said to you before, it might be just incidental when they went for their pap smear and the GP has noticed that there's been a huge drop into the vaginal cavity, but they're not complaining of any symptoms. So these are the modifiable and non-modifiable risk factors. I'll just let you take stock of that. But this is the worst case scenario. So this is called prostodentia, when you have complete aversion of the vagina out through. You don't see that very often unless obviously it's been neglected. But usually, if you don't look for it, you'll never find it. So basically, we've had a patient that came through emergency the other day with obstruction, and they're wondering why they can't put a catheter in, because this particular prolapse was in their way. So I think you're going to have to examine them if you want to find out how you can best serve your patients. Now, so I'm just going to briefly talk about the compartment. So as I said to you before, the anterior compartment is where the bladder sits. So if that's predominant prolapse, you're going to call it a cystocele, and that's usually associated with symptoms with either UTIs or not being able to empty properly. So this is the normal anatomy, and this is a rectocele that you can see on show here. That's when the bulge of the rectum comes through. So that usually means that they have difficulty trying to empty their bowel movements. And then this is obviously the vault, which actually has ruptured through, prolapsed through, and it's showing. And most of the time, if the vault is actually down, the bladder would be as well. So they can often coexist. It's not basically one compartment or the other. So they can all be mushed up together. And also, sometimes you can have bowel that actually prolapses into the vagina as well. And this is actually an open technique vaginally that we can actually address to actually restore or reconstruct. So how do you actually treat? So as I say, if it's not too bad, you can do pelvic floor exercises. If they're not wanting to surgery, you can use pessaries. And if they want surgical intervention, then you can offer them either a vaginal approach repair or a sacrocolpopexy. So the transvaginal mesh is actually out of, because of all of that mesh issue. So this is actually what we mean by native tissue repair. So we actually make a cut in the vagina and we suspend the vagina to these ligaments here. So that's what we call a sacrospinous ligament fixation, and you would do it on both sides. And this is the sacrocolpopexy. So you put a little bit of synthetic tape and you actually just attach it to the sacral promontory so that you can actually restore the prolapse back into the pelvic cavity. The fact that it's actually quite a difficult entity to actually diagnose, but we'll just go through some of the main frameworks. So basically, it is a painful bladder syndrome. So the most predominant component of this is actually pain, not frequency, not urgency, and not dysuria. And actually, it's actually a differential, well, it's actually a diagnosis of exclusion. So you can't say somebody is actually have interstitial cystitis unless you rule out all the other causes, including cancer. So that's actually very important to make that distinction. And how prevalent is this? It's actually quite prevalent. If per population of 100,000 female, as they age, they actually get a spike. And usually it's around about 40 to 50 when they actually get this problem. But it's a very complex pathophysiology because there will be an initial insult into this, and then it causes a bladder urothelial dysfunction. And there is a theoretical loss of that protective layer of the urothelium, and you can actually leak these substances through it, and that causes inflammation and pain. So, as I said to you before, pain is essential, but you also get some pressure effects within the bladder and frequency, urgency, and it's very sensitive and very, very highly associated with menstrual stress. So most of the time, these women can be quite depressed or anxious for that matter. And also the substantial amount of them will actually have pain on intercourse and also irritable bowel syndrome kind of symptoms as well. So these are actually all sort of tied in together. As I said to you before, I've had women who have actually voided up to 60 times a day because of this, but the predominant problem is they can't hold urine because they have pain. And usually if they urinate, the pain gets better. So that's actually one of the key differentials. But obviously you have to sort of rule out all the other causes. And most importantly with women in particular, because it also happens to see it in men. And usually in men, we will call it chronic pelvic pain syndrome. And that's usually what we say is chronic prostatitis, which is not a very fair term to use. But we have to make sure they don't have an infection or cystitis that are not infective in nature. And secondly, they don't actually have any cancer. So CIS can typically present this way, but also in gynecological problems, endometriosis sometimes can present this way as well. And as I said, any other of the adnexal abnormalities or any bowel problems, they can often have an impact on the symptoms as well. There is a lot of work done on this, and only there's only a handful of people who are interested because it's such a difficult thing to manage. But they have all of these symptom scales that they use, but we don't tend to use them very often here, just because it's too complicated. This particular O'Leary symptom complex, there's like 50 questions on that questionnaire. Like, it's impossible to fill out when you're actually trying to assess somebody like this. There's not much that you can see either with the physical exam. They may be a little bit tender when you do them, when you do the vaginal exam, but by and large, you know, it's pretty much is normal. And so you would actually have to do certain things like hydrodistension, cystoscopy, to actually see whether they have any features. So these are the features that we talk about with interstitial cystitis. We see this glomerulation as we fill the bladder, and then these ulcers that develop. And so if these ulcers develop, we can treat them and the patients do get better. But as I said, there's an overlap between overactive bladder symptoms and interstitial cystitis. So, you know, because the symptoms are not that generic, they're quite generic, they're not specific to the disease. So I think you have to have all of these in order to say that they've got interstitial cystitis, which is quite a lot. You know, imagine trying to work up all of this within a 6-minute kind of consultation. It is impossible. So this is a little bit about, you know, obviously the predominance in female gender having the problem, age more than 40. They usually have other chronic pain symptoms. And oftentimes, you know, very non-specific kind of signs, very subtle. But look at the treatment options. You know, we'll have 6 lines of treatment options. And the last one is obviously the most substantial, which is actually cystectomy. But I think for GPs and for us, you know, we would actually obviously work up until here, up until the 4th line, because when it comes to giving cyclosporin, that's entirely a different management. So usually we would refer these onto, you know, a subspecialist who have an interest in interstitial cystitis. Again, I can tell you now within New South Wales, there is no one, just because it is quite complicated to actually manage these. But if anybody that comes through, we would already have tried antimuscarinics or mirabegron. We would have given them some of the oral medications, and then we would obviously instigate intravesical therapy. If not, then we would actually proceed onto cystoscopy and then Botox injections, and then finally, you know, all the other ones. If it becomes a lost cause, then we would actually consider a cystectomy. So it is actually a very complicated disease entity, but just don't label it as interstitial cystitis because it needs to be carefully worked out. But so these are some of the medications that are available to treat that. You know, as you can see, you know, most of them are off-label use. So that's actually the end of the presentation. So I hope I haven't bored you and talked too much, but I'm happy to take more questions if you've got them.
No, thanks, Dominic. There are a couple of questions.
Yeah.
Firstly, we sort of touched on this before, but the post-micturition residual, just what's normal for men and women, different age ranges? Does it make a difference? Just can you sort of summarize what's normal for that value? Because we do often have to.
I would say a PVR more than that. Yeah, a PVR more than 100 is abnormal for me.
Okay.
Yeah.
That's okay. Yeah. That's a good number to go by. Okay.
Yeah.
Also, a question early on was using tamsulosin in renal colic.
Yes.
Which is often done. That's pretty standard practice these days, is it?
It is standard practice, but the evidence is mixed. So there are certain papers that are positive in terms of its effect, and you have to sort of qualify, you know, using tamsulosin because it doesn't really make the success of spontaneous passage if stone was lodged in the upper ureter. So most of the papers are indicating lower ureter and less than 5 millimeters. So if anything more than that, it falls out of that particular criteria, it is not so successful. But the meta-analysis data on that particular topic is actually negative. So really, it doesn't help. But we do it anyways. Yeah.
Okay. Great.
Yeah.
Now, another question. So that situation where we have a patient with dysuria and we do the MSU and it just comes back with high urea but no growth, and this often happens repeatedly. What's your sort of take on management of that patient and what's going on in that situation?
Well, steroid pyuria is almost the same management as hematuria. So if there's increased white cell counts in the absence of a UTI, it's either that you've recently just treated the UTI and it hasn't actually completely resolved, or there's still ongoing inflammation. And you don't necessarily have to have blood in order to detect urothelial carcinoma. So you would actually, if they're actually at risk for example, if they have a smoking history, you would do urine cytology and you would refer them on to actually do a cystoscopy because you need to know inside the bladder what's going on. And sometimes, dysuria, dribbling and pain are often a triad for urethral diverticulum. And so sometimes when we do an MRI scan, we can often see patients having sterile pyuria, and that matches a urethral diverticulum. Yeah. Okay, but sterile pyuria, if it's persistent, it's the same as hematuria. You just have to refer on for cystoscopy. Yeah, it's one of the red flags. Yeah.
Okay. Another question: how do we easily differentiate between uterine, rectal, or bladder prolapse in our rooms? I suppose it's an examination.
Yeah, you can see it coming out. So basically, what happens is, if anybody has a vested interest, what you do is just use half the blade of the speculum and you push in different directions. So you can just reduce the back wall, and you can see what happens with the front wall when the patient strains, and you can reverse that, and then you just reduce the front wall and see what happens with the back wall. So usually you would know whether which part is coming out, because the vagina is only so big. Unless it completely comes out, then the competing spaces to actually show. And so you can just reduce each compartment at a time to actually see which part is more predominant. But the symptoms will elude sometimes, yeah.
Yeah. And another question, probably our last one. So someone's written trigonitis, which I've got to be honest, I'm not quite sure what that is, but I've heard of it. Trigonitis, what is the management of that? What's that referring to?
So trigonitis is basically cystitis cystica. So inflammation that is actually within the trigone area of the bladder. And so that's actually a sign that you have chronic or recurrent UTI. So what happens is, just above and beyond thinking that, the bug sits in the bladder and it irritates it and then you get a UTI, these bugs also can actually be living symbiotically underneath the urethral layer, but occasionally it can cause problem. And when you actually take antibiotics, it's processed and the drug actually just gets passed into the urine, and that's how it acts, but it doesn't penetrate through the urethral layer. So trigonitis means that there's a persistent infection that's subepithelial, and sometimes just by giving them antibiotics after another doesn't resolve their symptoms. So they can keep on getting recurrent infections. And so occasionally you have to have low dose antibiotics once you've treated the acute incident, meaning what I do normally, if somebody has recurrent UTIs, which means they have more than 4 episodes during a year, that's the definition, then I would actually treat them with a 2-week course or 1-week course, and then put them on prophylaxis for 3 months, sometimes even up to 6 months. And if they have any breakthrough infections, that I tell them that they will probably require a cystoscopy. And if I see these pockets of inflammation within the trigone, that's why it's trigonitis, then I would actually diathermy them to actually exfoliate their bladder. Yeah, so that's actually been shown to be quite helpful if you're sort of exhausted, all of your conservative efforts to actually get the UTI under control.
Right, but you'll make that diagnosis at cystoscopy.
Trigonitis, cystoscopy, yeah. So trigonitis will give you hematuria and sterile pyuria. So you put it on the urine, but you definitely need to put a camera in there to actually visualize that change. Yeah.